Good morning, everybody. Thanks very much for coming to hear us today. So before I start, how many of you work in an office or location where there's a provider doing Botox injections? Pretty good. All right, excellent. All right. So we'll talk about botulinum toxin for a little while, and then we'll do a brief detour to talk about BCG bladder instillations, which is not part of my specialty. So I'll give you the lowdown, but I'm going to tell you to hold your hard questions for Dr. Stevenson, who'll be after. All right, so botulinum toxin, we'll talk about indications, how it works, what the procedure actually looks like. We'll go through some outcomes and adverse effects from botulinum toxin, and then, as I mentioned, a little detour for bladder instillations and bladder cancer. Again, we'll talk about indications, the AUA SUO strategies for dealing with the BCG shortage, and briefly some other intravesical agents. So, botulinum toxin, right? Everyone hears about this in the office and they're like, what? Botox in the bladder? Like, what is that? We're all very familiar from pop culture with the cosmetic uses of Botox. I think it's always kind of exciting but surprising to patients when we talk about injecting into their bladder. So a brief history of botulinum toxin. Earlier in human history, the bacteria that causes or that produces botulinum toxin was really just known as a foodborne illness, right? So back in the 1820s, I don't think he was a doctor, Justinus Kerner, I think he was a journalist actually, identified foodborne botulism toxin as a cause of the very dramatically named sausage deaths in Germany. He could kind of put together, there was this spate of deaths from this prepared food, and he realized there was a biologic cause, and that it actually was not exactly infectious, but he kind of put together that there was a toxin at the root of this. Clostridium botulinum, the bacteria that produces botulinum toxin in nature, was identified in 1895. The actual toxin and the subtype that we use was isolated in the 1920s. And very shortly thereafter, the Americans and the Japanese and all the participants in World War II decided they would like to investigate how to use this as a biologic weapon, alarmingly. It was actually, there were some experiments done during World War II feeding essentially botulinum toxin to prisoners of war in the Pacific Islands, yeah. Not surprisingly, it caused death just like botulism can. In the 40s, the folks who had been involved in investigating botulinum toxin as an agent of warfare realized perhaps there were some more humanitarian uses for this compound, which paralyzes muscle. And so Edward Shantz began preparing batches of crystallized toxin and using it in animal experiments. And much later, in the 70s, got together with an ophthalmologist, Dr. Alan Scott, and they worked together to research use of this toxin in conditions where muscle tone was an issue. So they used it in strabismus initially. In 1989, they had a product that could go onto the market, and the FDA approved Botox for blepharospasm and strabismus. Very quickly afterwards, other folks started utilizing botulinum toxin for other purposes, or they're kind of able to leapfrog off of what these guys had discovered. Someone realized it could be used for cosmetic purposes, and in the 90s, this was already being popularized in Hollywood by Madonna and Tom Cruise, Michael Jackson, right, and others. So they were using it off-label at that time, but for cosmetic purposes to reduce wrinkle lines. And for the purposes of urology, in 2013, the FDA finally approved Botox for overactive bladder. That was the first urologic indication. So a long meandering history. And just quickly, kind of what is the point of having an intravesical therapy, right? We're all familiar with taking a pill, but why do we actually do a bladder therapy? And so, both the combined issue that endoscopically, right, pretty minimally invasively, we can give a very high concentration of the pharmacologic agent of interest directly to the target tissue, right? So that's one advantage over an oral therapy. And then we can avoid the systemic side effects of an oral therapy, right? We don't need to give the Botox to the entire body. In fact, we do not want to give people botulism, all right? But we can avoid side effects, and at some point I'll go on my tangent about anticholinergics, right, and all the kind of adverse effects we see with the drugs for overactive bladder. We can totally bypass that issue by essentially, it's almost like a topical therapy, right, to give it directly into the bladder. Another note on the downsides of oral therapy for overactive bladder is that not only are there quite a few systemic side effects, but also they're not tolerated very well. So, something like 20% of patients will stop their oral therapy after a year. So, and get lost to follow-up, stop, come back to the practice. They kind of assume there's nothing else out there. So intravesical therapy also is much better tolerated and has much better kind of durability as a repeat treatment. There we go. Okay, so officially approved indications for botulinum toxin are overactive bladder, right? Urgency incontinence, frequency, urgency nocturia, in adults over 18 who had an inadequate response or are intolerant of anticholinergic medications. And the other officially approved indication for botulinum toxin is neurogenic bladder, urinary incontinence due to a detrusor overactivity associated with a neurologic condition, and the best studied neurologic conditions are spinal cord injury and multiple sclerosis. Again, adult over 18, inadequate response or intolerant of an anticholinergic medication. Now there are some off-label uses within the world of urology. One is use in children, actually. So the pediatric urologist will use botulinum toxin. I'll talk a little bit about that. Interstitial cystitis, bladder pain syndrome. Many of you probably know, botulinum toxin is in the AUA guidelines as a third or fourth line therapy for interstitial cystitis. All right, it's not specifically approved by the FDA for that purpose. Usually when we use it, we kind of say they frequently do have urinary frequency, and so we can kind of do an officially approved diagnosis for them there. But there are probably some benefits directly from a sensory pain perspective. So we'll talk a little bit about that. And then more in the research world, botulinum toxin has been used actually directly into the prostate as a prostatic injection in BPH, with the idea that it induces some apoptosis of the prostate tissue, and perhaps is a less morbid treatment compared to surgical resection. That's very off-label, really only used in clinical trials. I'm not familiar with anybody, I've never heard of somebody using this clinically outside of a study protocol. And the bottom line is it's probably not terribly effective, but for completeness, many different things we can do in the world of urology with Botox. So before I launch into chatting about the drug, I'll tell you a little bit about the bladder structure and function. I want to lay the groundwork for how the Botox actually works, right? So I meant to get Alan Wien's picture in here, but so many of you are hopefully familiar with the idea that in the micturition cycle, we have the filling and storage function of the bladder, right? The bladder's job is to hold urine at a low pressure until a socially appropriate, voluntary time to void. And then the second function is the emptying and voiding phase. And the bladder's job at that point is to empty to completion, right? So Alan Wien is a urologist and researcher at the University of Pennsylvania who really created all these paradigms. You hear urologists ever talk about like failure to store, failure to empty, just kind of these big picture concepts for how we think about what the bladder should be doing and where it's failing in various kinds of dysfunction. So overactive bladder, specifically, we usually think of as a failure to store, right? Because the bladder is not doing its job of holding on to things until an appropriate time, okay? Quietly at a nice low pressure. So some filling phase properties that we think about when we're looking at the bladder, a big one is compliance, or the stretchiness of the bladder. So compliance in a physics sense means a change in volume relative to a change in pressure. Okay, so the bladder is biologically designed. So is this working? There we go. It has this really unusual lining, right, the urothelium, and its very specialized function is to be able to stretch out and fill and hold on to 300 or 400 cc's of fluid, right, without changing the pressure in that viscous organ. It's really unusual. So when we look under the microscope, it has this really unusual lining. It's kind of heaped up with multiple layers when the bladder is empty, and it will stretch out, and the urothelium will actually thin when the bladder is full. And the vasculature had to evolve to support that kind of thing. There's a very complex motor sensory network to support this function. So here, this is the urothelium with the lamina propria, and this is not the detrusor, actually. This is just the muscularis propria, so the little muscle cells that assist the urothelium itself. And then just kind of a close-up of the urothelium, so you can kind of see these really heaped up cells in this sort of epithelia, but really super specialized layer. And the other thing the bladder does, right, is that once your kidneys have done the work of excreting the urine and deciding how much water and salt and other products to stick in there, we don't want to reabsorb it, right? So the other job of the bladder is to not allow any absorption of urine back into the body, all right? So that's a lot of work, actually, that our little bladders are doing. Viscoelastic bladder is driven by neuromuscular and mechanical properties. So there's some passive structures that allow the bladder to be stretchy and store pee at low pressure. So there's a lot of smooth muscle. There's collagen and elastin, right? And there's a pretty high elastin, right? Just these tiny little fibrils within the bladder that allow that stretchiness. Injury, obstruction, kind of long-standing BPH, denervation from different neurologic insults will gradually cause the collagen content in these layers to become increased, right? That's fibrosis on a microscopic level. And when that happens, the stretchiness, the compliance of the bladder becomes impaired and changes. Then there's kind of an active component to the bladder's compliance, right? So central nervous system input is actually required for compliance, okay? So it's not just operating in a vacuum, but there's actually a constant input from your brain to the bladder telling some of these smooth muscle fibers just to stay relaxed, okay? And we know in spinal cord injury, when that input disappears, the resting tone of these muscle fibers is higher. Okay, so this will be relevant later. And then active afferent signals during filling inhibit smooth muscle contractility. So when the bladder is at 30 cc's versus 130 cc's versus 530 cc's, right? That there's a constant adjustment going on where the bladder senses how stretched out it is, sends a signal up to the spinal cord and back down through the motor pathway, telling the muscle to relax a little more, right? So all this is to say there's a passive structure to allow bladder compliance or stretchiness, and there's also this active component, this constant micro-adjustment that's actually really important for allowing our bladder to store pee at a low pressure. And the reason we care about storing urine at a low pressure is because if you have high pressures in your bladder, you guys hopefully know about this, right? It can cause kidney damage. So back in the 70s and 80s, one of the very early papers on spinal cord injury patients showed that a major cause of death was end-stage renal disease that was actually caused by the bladder dysfunction. All right, so that's why we care about this so much. All right, and then moving on to the another component of the filling phase of the bladder is detrusor overactivity, right? A pathologic component, but one that's important for our talk today. So normal bladder smooth muscle is spontaneously active. I think I have a picture of this, or at least a schematic of this later. So there's all these smooth muscle cells. It's not a skeletal muscle, right? It's a smooth muscle. It has spontaneous activity, and that spontaneous activity usually is a little random and not enough of a contraction to cause pressure changes in the bladder, but in disease states that can change and lead to problems. There are gap junctions, there are little connections between the smooth muscle cells that allow for electric coupling. So when the detrusor is supposed to be squeezing, right, the squeeze signal gets propagated through the smooth muscle in a nice, coordinated, easy way because the cells are linked up to each other. However, those same gap junctions can trigger spontaneous contractions that are either not too bothersome and not causing pressure problems. We call that micromotion, and that's a feature of normal bladder. However, that's the sort of laying the groundwork for possibly a pathologic state in overactive bladder where those contractions become exaggerated and can cause symptoms, right? Interstitial cells, also called myofibroblasts, are non-muscle cells that are kind of throughout the bladder and detrusor layer, and they're actually very involved in all of these activities. So they're also spontaneously active and kind of coordinating activity between the muscle cells. And here's a little schematic. These little yellow guys are the myofibroblasts, okay? And then here's the detrusor smooth muscle cells surrounding them. So the interstitial cells or myofibroblasts are located in the suburothelial layer and also in the detrusor layer itself. They are not directly contractile, right? They're not muscle, so they're not involved in the actual squeeze, but they're believed to have an important role in the pacemaking function, meaning they're probably responsible for actually generating the micromotions that normal bladders have, and they also propagate signals between detrusor muscle cells during detrusor contraction. That's on purpose, okay? And these myofibroblasts exhibit many of the receptors that we're going to talk about shortly, just like the smooth muscle cells. So all this is to say our plumbing is actually very complicated. All right. Smooth muscle and myofibroblasts respond to cholinergic stimulation by the muscarinic subtype 3 receptor activation, okay? And I've got some pictures of this later, but I bring this in because, right, we talk a lot about anticholinergic, antimuscarinic medications, right? And botulinum toxin is going to work on those same receptors, okay, by a slightly different mechanism. But the bladder is very richly innervated, again, muscle and also in the connective tissue with these receptors that we use as our drug targets, right? That makes sense. Both smooth muscle and myofibroblasts are involved in development of detrusor overactivity, which I mentioned we kind of conceptually think of as storage failure. Okay, and then the voiding phase, okay, of the micturition cycle. So pressure in the bladder, right? How many of you are involved with urodynamics? All right, good. So some of these concepts will be a little familiar, okay? So intravesical pressure, the pressure in the bladder, is the sum of the pressure generated by the detrusor muscle itself and also the pressure from the abdomen, right? And if your BMI is 50 versus 25, that P abdomen number is going to be a little different, right? If you're doing a Valsalva, then your P abdomen is going to be a little different, okay? And then the reverse of that, what we use in urodynamics, is the detrusor pressure itself is the pressure in the bladder minus the pressure from above the bladder. Parasympathetic activation, and that's our rest and digest nerve system, right? Activation by acetylcholine leads to detrusor contraction, okay? And again, these key words that are going to come up with the drug targets and also with the botulinum toxin targets, okay? Purinergic activation by ATP, okay, which is just a small molecule that can be released from the urothelium, can also induce contractions. And that pathway is probably really important in disease states like overactive bladder and also in interstitial cystitis, okay? For a normal healthy bladder, that's a minority of the signaling and usually not the cause of a contraction. Muscle can use energy, right, in general, to generate force or to shorten its length. Okay, so the bladder muscle, which is a hollow organ, right, can generate force, which increases the detrusor pressure, or the muscles can shorten. I think I have a picture of this later. And when the muscles shorten, the bladder changes its shape. So again, getting to this idea that the bladder is actually more complicated than it appears, the dynamic change in shape that happens in the bladder, particularly around the bladder neck and trigone, are as responsible for voiding as any increase in pressure, okay? So there's actually this very complicated interplay that happens to allow us to pee. In women, and this is a good example, right? Female versus male voiding. In women, if the urethral resistance is much lower, right? There's not much to the outlet compared to a male urethra. The detrusor pressure may be 0. It may be like not detectable, but there's still force being generated in the detrusor muscle. It's just that it probably contributes much more to the shortening and change of shape in the bladder organ, more so than generating force, which is necessary for a man to pee. The mechanical power, right, just kind of the work that's being done by the bladder, depends on the pressure from the detrusor and the flow, okay? So in women, when the urethra opens widely, right, and they can have a nice high flow, they don't need much detrusor pressure for the same voiding power as a man, okay? It's kind of like work done by the muscle. Voiding nomograms developed for men with outlet obstruction, which is what pops up on all the laboratory urodynamic reports, are really not applicable to women at all because our voiding dynamics are actually very different. And this is just a schematic of how all those little detrusor smooth muscle cells have this very complicated linking by different fibers, by nerve terminals. I think we have the parasympathetic cholinergic receptors and also the purinergic receptors I mentioned as well, right? So just very richly innervated on all these cells to coordinate this activity. And this is just a schematic of, again, that muscle shortening that can happen, right? So here's a relaxed smooth muscle cell, and then when the muscle contracts, if that contraction is mostly geared towards changing the shape of the muscle, and you amplify this, times hundreds of thousands of cells, right? You're going to have a big change in the length or stretchiness of the entire bladder muscle. And so there's all these little filaments and kind of fancy equipment that help the bladder muscle achieve this. This is a schematic of the, not the current, blue, whatever, red-green Abrams Griffith nomogram that appears on our urodynamic reports, but this was actually from the original publication, kind of demonstrating what pressure to flow in general is obstructed in a man versus kind of equivocal or not obstructed. So again, I know this prints out on every urodynamic report, but it's actually really not applicable for women. Female voiding is actually like much harder to put a proper number on. So just so you know, not applicable for women. And this is just a schematic of those micromotions I was talking about earlier, where the detrusor smooth muscle cells and those myofibroblasts can generate spontaneous little contractions. This is happening, in me, probably a little extra after all my coffee, but in you, you don't feel it. It's happening all the time. Those gap junctions can cause it to spread a little bit, okay? But usually that's kind of the extent of it. That's a normal bladder. In overactive bladder, the micromotions get like really amped up, okay? And they can be happening in multiple sites at once. They can trigger, pseudo contractions or complete bladder contractions. And while that's happening, the bladder is sensing what's going on, right? Because there's that really sophisticated feedback mechanism. And so when this is going on in your bladder, you're going to have much more a sense of urgency. I have to go, compared to this person. We don't need to go into detail on this, but just, again, a schematic to underline my point that the bladder is actually super complicated. There's nerve receptors in the urothelium, in the suburothelium, in the interstitial fibers, in the muscle fibers, and there's receptors for from the central nervous system, right? In all of those layers, they're all interconnected. It's a very, very sophisticated feedback mechanism, and everybody's kind of talking to each other, right? So the urothelium is telling the interstitial tissue and the muscle what's going on to coordinate, like I was describing, those micro adjustments that are constantly happening as our bladder is filling, and then during voiding. Now, when your machinery is this complicated, there's also lots of potential for things to go awry, right? So, getting away from the fancy bladder itself, there's the nerve control to the bladder, all right, and this will be relevant for our neurogenics. So, nerve control of the bladder comes from the central nervous system and the peripheral nervous system, and there's actually 3 separate nerve systems involved in bladder function. So parasympathetics, that's the autonomic system that does rest and digest, right? Also does voiding. So parasympathetic nerve fibers arise from the sacral cord, or at least the ones to the bladder do, and they are responsible for telling the detrusor to contract and the urethra to relax, right? And usually that happens together in a nice coordinated fashion so we can pee. Sympathetic nerve system, that's our fight or flight system. Those nerve fibers arise from the lumbar spinal cord, and they kind of do the opposite. They tell the detrusor muscle to relax, right? When you're running away from a lion, it's not a good time to pee, okay? Contract urethra and bladder base to maintain continence. So while you're stressed out or running away from a lion back in the day, we were not peeing when we were having these sympathetic discharges. And then there's the somatic nerve system, right, which is what makes you curl your biceps, the things we have more voluntary control over, also involved in bladder function, right, because voiding, at least part of voiding, is under somatic voluntary control. So the pudendal nerve is our somatic innervation to the urinary system, and it contracts the external urethral sphincter, right, the one that, and we also call this the striated sphincter because the skeletal muscle under voluntary control, that's another way to describe it. All right, so we have this very sophisticated innervation, and when the nerves are interrupted in various patterns, that sophisticated machinery can get screwed up in actually pretty predictable ways. So in neurogenic bladder, we can think of that as neuromuscular disease, injury, or dysfunction that alters the micturition cycle, right? Alters the filling, alters the emptying. You can get abnormalities in sensation. It can be absent or impaired. You can get abnormalities in detrusor activity. It can be overactive. It can be underactive or areflexic altogether. You can have abnormal compliance, right? You can have increased or decreased compliance. You can have alterations in the smooth sphincter, right? So we have a smooth muscle urethral sphincter, and we have a striated voluntary sphincter. And those are, normally they're synergic. The bladder muscle contracts and both of those urethral sphincters relax. However, depending on the pattern of neuromuscular disease, they can be dyssynergic. They can work against you when your detrusor muscle is trying to squeeze. Bradykinetic, that's a key word from Parkinson's disease. So in Parkinson's disease, where the skeletal muscle becomes impaired and slow, you can actually see the voluntary external urethral sphincter exhibit bradykinesis and just have a little delay before it opens up during peeing. All right. So as I mentioned, depending on the neurologic lesion, you can end up with a consistent abnormality depending on what area of the nervous system is impacted, what the physiologic function of the affected area is, and whether that lesion is destructive, right, like a motor vehicle accident, spinal cord injury, inflammatory, like multiple sclerosis, or it's another good example. I don't know, there's a bunch of them, like Devick's disease, or there's like many neurologic diseases that have more of an inflammatory action are going to behave a little bit differently than someone who had an injury from surgery or an accident, and other irritative lesions, so they'll affect things in a different way. I mentioned this a little bit before, but our normal bladder sensation, right, kind of feeds back, right? So we have signals to start voiding, starts in the brain, goes down to the brainstem that sort of coordinates all the sophisticated visceral machinery we don't have to think about. Those signals go down to the spinal cord, and then to nerves that go to the bladder, and then there's feedback coming through the sensory nerves. Right? So this is kind of what normal looks like, but pathologic state, these different types of fibers can become more prominent. It's like a pathway we don't use very much in healthy people, but it's an opportunity for disease states to have some outsized signaling. And this particular pathway is probably very important in interstitial cystitis. So, common patterns of neurogenic bladder. If you have a problem in the brain, right, so after a stroke, for example, you can end up with detrusor overactivity and incontinence because of detrusor overactivity. If you have a spinal cord lesion that's suprasacral, right, so above the level where the somatic bladder nerves come from, you can have impaired sensation because you've kind of blocked off this connection here. You can have detrusor overactivity. You can have sphincter dysynergia because you've interrupted the coordination of the signals to squeeze the bladder and you relax the sphincter. You can have urinary retention because of that. You can have overflow incontinence because of that. Complete spinal cord lesions above T6 can have all of those things, but they can also have dysynergia of the smooth muscle sphincter and autonomic dysreflexia, right? So these are the patients we really worry about when we're doing a cystoscopy or urodynamics. Autonomic dysreflexia is a condition where the signals that, my bladder is full, my rectum is full, instead, when those signals can't make it to the brain to tell you what's going on, at this level, they can end up generating massive sympathetic discharge, okay? And so, right, we see patients with the blood pressure can go up to 200. They can then get, bradycardic from that. They can end up with wild vital sign abnormalities very quickly because of this improper handling of the nerve signals that happens in those spinal cord patients. To wrap up the rest of the kind of nerve injury or disease patterns, right? So there's the sacral spinal cord injuries, and now we're getting to things that might more happen, from like a neurosurgery, a very low spinal cord injury, all right? They can have detrusor areflexia, right? They can't squeeze their muscle at all. They can have impaired compliance, okay, because that signal coming from the spinal cord to tell everything to stay cool and stay relaxed has disappeared. Their sphincter muscle can be kind of fixed and it doesn't relax or contract. It's stuck, okay? Peripheral arc interruptions. So after everything has exited the spinal cord, we can end up with problems. And think of like radical hysterectomy, radical cystectomy, after surgery where all those peripheral nerve fibers in the pelvis have been totally interrupted, okay? They can have motor or sensory, or both, right? Loss depending on where the surgery was. They have areflexia, their detrusors do not squeeze. They can have decreased compliance, same reason, right? They kind of lost that central nervous system inhibition on the resting tone. And this is all like pretty predictable. So these are the folks that had some kind of major pelvic surgery. They had an APR 5 years ago and they were never able to pee afterwards. Those are basically a peripheral nerve injury, right, from surgery. All right, getting back to the Botox, we've laid our groundwork. So botulinum toxin is a neurotoxin produced by Clostridium botulinum. There are multiple subtypes, and Botox subtype A, the one that is purified and developed by Allergan and that we use clinically, has the longest duration of action out of all the various botulinum toxin subtypes. So most clinically useful, okay? The dose units, by the way, between different subtypes are not interchangeable. So 100 units of Botox is not the same thing as 100 units of Dysport, just for example. There are 4 commercial forms of botulinum toxin A, all right, and they're wrapped by different proteins that modify its potency. So onabotulinum toxin A, commercially known as Botox, has the most clinical data in urology, being used intravesically. It is the bulkiest molecule out of these options, and theoretically that should limit diffusion into the bloodstream, which could potentially cause botulism, right, like the sausage deaths. Other options are abobotulinum toxin, commercially called Dysport, incobotulinum toxin, Xiamen, I'm not sure that's available in the US, and Prosigne, which doesn't have a non-commercial form, and that's really exclusively used in China. Dysport has been used for other neurologic indications. There's more research on using Dysport for like cerebral palsy and other kind of non-urologic causes, but most of the urologic data comes from onabotulinum toxin, Allergan's Botox. There are studies that have investigated Botox subtype B. That drug is called remabotulinum toxin B, or myoblock, or neuroblock. It's out there, but generally not clinically used, not enough data. So botulinum toxin works by blocking neurotransmitter release, okay? And the upshot of what happens is we can affect contractility. We can, like kind of voluntary contractility. We can alter the resting tone, right, of the smooth muscle, which is responsible for compliance, the stretchiness of the bladder. And we can also impair sensation, okay, which in overactive bladder is a good thing. All right, to get into the nitty-gritty. All right, so botulinum toxin is most extensively studied in striated voluntary muscle. That's where the neurologists or the dermatologists inject Botox. Acetylcholine release is blocked from the motor nerve endings, leading to paralysis. And when it's used in striated muscle, the effect only lasts 2 to 4 months. So if you're going to your dermatologist for Botox for your crow's feet, it's like you have to come back every 3 months because that's just how long it lasts in striated muscle. Fortunately for us, it lasts much longer in the smooth muscle of the bladder. So Botox actually targets all those nerve pathways we talked about earlier, okay? They target the parasympathetic, sympathetic, and somatic sensory nerve fibers in the bladder. Acetylcholine blockade is essential for stopping detrusor contractility, right? So in overactive bladder, we want patients to stop getting detrusor overactivity. And so this will block it. And the way it works, I don't know if this project's quite big enough for you guys, but there's these group of proteins called snare proteins that help join these little vesicles containing acetylcholine at the nerve terminal to then be released postsynaptically, and these receptors are the muscarinic receptors, right? So antimuscarinics get into the nerve terminal and directly block these channels, okay? Botox has this very sneaky activity where it goes backwards into the presynaptic terminal. It binds to a protein, gets into the cell, and it cleaves these little proteins that are involved in vesicle release, okay? And the reason it lasts longer in smooth muscle is related to the fact that it cleaves these proteins, and when we do, like, say, a bladder biopsy 6-8 months later, these targets are still cleaved, okay? So they kind of like regenerate more quickly in striated muscle. The reason Botox lasts longer is these proteins stay inactive much longer in the smooth muscle of the detrusor. All right, so when those are cleaved, the acetylcholine cannot release, right? So we're kind of blocking acetylcholine activity, and that helps us impair detrusor contractility. All right. Sensory impairment, all right, also a really important clinical effect of Botox. So not only is this happening at the junction between the motor nerves and the detrusor muscle fibers, but it's also happening in that complex nerve network I was showing you with the urothelium, suburothelium, the nerve fibers that send the sensory signals, that I'm full, right, signals, also get impacted by botulinum toxin and cleaving these snare fibers. So botulinum toxin also inhibits spinal cord release of glutamate, substance P, and other neuropeptides that are involved in pain, okay, but also normal bladder sensation. So after botulinum toxin, we know that the sensory nerves from the bladder back to the central nervous system are not firing as frequently. And this is probably an underappreciated but extremely important action of botulinum toxin, the sensory piece of things. Botulinum toxin inhibits bladder neurotrophins. So these are kind of like the growth compounds and compounds that mediate plasticity, probably somehow involved in making botulinum toxin last so long after the injection, but this activity is actually not well understood. And then, as I mentioned, botulinum toxin lasts much longer in smooth muscle, actually up to 12 months, much longer than when we use it in skeletal muscle on our faces. All right, so the actual procedure, all right, just starting with the prep, right? We want to make sure we're using the therapeutic formulation of botulinum toxin. There are certainly some urology offices who have gotten into the cosmetic side of things, but probably most of our offices only stock the therapeutic formulation. And since the FDA approval and insurance reimbursement for those products are different, right, make sure you're using the right one. It says intravesical right on the box. Check your expiration date. When the Botox is crystallized, it actually lasts for 3 years. It has a really nice shelf life. It's refrigerated, really cold, right, 2 to 8 degrees Celsius, and it will last those 3 years at that temperature. However, if it got left out by accident, for example, over the weekend, it's actually still okay. It's stable at 30 degrees Celsius for a week, okay? So being out of the fridge for a couple of days doesn't mean you have to toss it, but you do have to use it kind of quickly. The vial looks empty, right? It really confuses people. This Botox vial is full. There's this kind of like light powdery ring. That's it, all right? That's how it looks. So don't panic and throw your Botox vials out. They look empty. The vacuum dried toxin looks like these tiny little clear crystals, and it is a really small volume. We'll talk about reconstituting, but once you've reconstituted, you want to prime your injection needle either with the reconstituted toxin or just with normal saline so we don't inject the bladder with air. To reconstitute the toxin, we use sterile, unpreserved normal saline, okay? So that's not the saline that we use to irrigate the bladder. That stuff's actually not injectable, okay? But the saline that comes in little vials that could also be given intravascularly, that's the one we use, okay? 10 cc's for 100 units. Traditionally, okay, like in the papers that were published about Botox, 30 cc's for the 200 unit dose, although many of us will dilute it down because that's an awful lot of volume meant to be injecting into the bladder. And then usually we'll use a flush to get the last bit of this expensive stuff into the bladder. And once you mix it up, you should use it immediately, or if stored properly, the reconstituted Botox is okay for up to 24 hours. The actual injection procedure, we have this kind of classic template that was published in all the original clinical trials on botulinum toxin. Traditionally, it was done in a trigone sparing fashion, right? The trigone is this area where the ureteral orifices are. They were very worried, urologists were very worried that if we injected the trigone with Botox, we would cause reflux, okay, by sort of like interrupting the antegrade propulsion of urine down into the bladder. However, like after all these studies were done, a lot of people do trigone injections. I do, I think many urologists do. The trigone is also very, very richly innervated from a sensory perspective. And as we've talked about, the sensory action of botulinum toxin is super important, okay? And there's been no real clinical proof that this causes reflux. Right? It was just sort of a theoretical concern. 2 millimeter needle depth to get into the detrusor muscle through the bladder wall. Injections are supposed to be about 1 centimeter apart. When you're doing the 100 unit dose, you're supposed to do half cc aliquots at 20 sites, and we usually kind of think of these rows of 5, right? When you do the 200 unit dose, as originally published, 30 sites in 1 cc aliquots. And then a final injection, right, to kind of clear your needle of this expensive product. That's how it looks, and here's a little side shot showing that 2 millimeter depth, right, getting right into the detrusor muscle. Best practice for documentation, you should always talk about what dilution you used, you know, whether you delivered all the Botox or not. Lot numbers can be important. You know, some insurance companies use specialty pharmacies and they demand that you use the Botox from a particular place. And so documenting the lot number, right, will kind of help account that yes, we use your special Botox, right, and not just the Botox that the office prepares. And so sometimes that's an insurance company issue. Record the number of units delivered, if anything was wasted, right, because we don't want to charge patients if we didn't deliver the entire prepared dose. And then you repeat treatment, either when symptoms recur at 6 months, some people need it more than every 6 months, so you can kind of tailor. Important number to know is that the maximum dose is 400 units in a 12-week period. So patients who are getting botulinum toxin either cosmetically or because of muscle spasm, right, by their neurologist, you have to keep track of this because you could actually easily overgo, and there's no published data on safety from botulism, essentially, at doses higher than 400 units in a 3-month period. Okay. Outcomes. So many randomized clinical trials looking at botulinum toxin action. Compared to placebo, really effective at decreasing incontinence episode, decreasing urinary frequency, decreasing the sense of urgency, improves quality of life significantly. People can go out and go to the grocery store again and see their friends and not feel like they have to stay at home to be near the bathroom. Magnitude effect versus placebo is 2 to 4 fold, which is a much stronger benefit than previously described with antimuscarinic drugs. And interestingly, well, not so interestingly, because I've already told you guys why, right? It doesn't really matter whether the patients have detrusor overactivity at baseline, and that's because of that sensory action of botulinum toxin, which is super, super important. Okay. 20% of patients in some of these earlier studies said they were completely dry after botulinum toxin, and I think actually more recent data is even better. Big clinical trial comparing botulinum toxin to the kind of current standard of antimuscarinic therapy. This is called the ABC trial. They looked at sulfenacin, which is Vesicare, plus a sham injection compared to Botox 100 units and a sham pill over 6 months, and there was an option to escalate the medical therapy over that time period as needed. They had similar reductions in urgency incontinence, but less dry mouth, right, cognitive effects in the botulinum toxin group. And of course, the botulinum toxin group had more adverse effects related to the Botox itself. One final major trial that I'll mention on this is the Rosetta trial, which compared botulinum toxin to sacral neuromodulation, right, another really popular third-line therapy for overactive bladder. They compared 200 units of botulinum toxin compared to sacral neuromodulation over a 6-month period in over 300 patients. This was predominantly performed by urogynecologists. They only looked at women, and they only looked at people with urgency incontinence, okay? And they found that there were fewer incontinence episodes per day they did bladder diaries, and they saw almost 4 fewer episodes of incontinence per day in this sort of select population with really severe baseline symptoms, right? A little bit better than in the sacral neuromodulation group. Symptom scores and satisfaction were slightly better in the botulinum toxin group. However, in cancer, when they're looking at their outcomes, they have these very convenient objective outcomes, right? Progression-free survival, mortality, right? It's like very black and white. It's very easy to look at and understand. Is important that you live 3 months longer? Is important that you live 10 years longer, right? You can kind of like look at that data and know what it means. In a more quality of life field, what is the importance of this stuff, right? Do people really care if they have 3.3 fewer or 3.9 fewer incontinence episodes per day? Is that meaningful? And the answer is it's probably not. And there are studies that correlate overall patient satisfaction scores, more general quality of life measures, right? That we can use them as a rubric to look at things like reduction in incontinence episodes or OABQ symptom scores, right? To kind of like, what are we really doing here, right? It's kind of like a reality check. So based on all published data on these quality of life measures, although Botox performed better in this study, it's probably one of those things that's statistically significant, but perhaps not clinically significant. So what I take away from this trial is both botulinum toxin and sacral neuromodulation are doing a great job. Right? Side effect profile is a little different. And I don't know why they did this, because the starting Botox dose for overactive bladder is 100 units. I don't know, I think they had an agenda. I don't know what else to say about that. In neurogenic bladder patients, similarly, and again, the clinical trials in this population was very heavily focused on spinal cord injury and multiple sclerosis patients. Similarly found decreased incontinence episodes, decreases in urinary frequency, decreases in that sense of the severe urgency, improvements in quality of life. There's a few special populations that have a lot of botulinum toxin data, so I'll talk about them briefly. And that's Parkinson's disease, multiple sclerosis, and spinal cord injury. So Parkinson's disease, neurodegenerative disorder in the central nervous system, right, affecting dopaminergic neurons. These patients classically get tremor, skeletal rigidity, right? So their voluntary muscle tone is really tense, and bradykinesia, it's difficult for those muscles to relax up, okay? Really common to have some kind of voiding dysfunction in Parkinson's patients. They can get frequency, urgency, nocturia, urgency, incontinence. On urodynamics, they often have detrusor overactivity. And then there's that entity I mentioned previously where they can have this pseudo dyssynergia, or the striated sphincter is also bradykinetic like the rest of their skeletal muscle. So sometimes on urodynamics in these patients, you will see the EMG activity increase, right? You can see that muscle contracting against the bladder trying to pee. And then after a delay, it will relax up. And if you're not paying attention, it looks like sphincter dyssynergia, but it's slightly different and probably less dangerous than a true sphincter dyssynergia. There's a lot of historic confusion with another neurologic diagnosis, multiple systems atrophy, in old literature. They were not parsed out very well. And so people used to say that you should not TERP Parkinson's patients. And that's probably a myth related to the fact that in multiple systems atrophy, their external sphincter cannot contract at all. And so when they were TERPed, they were more likely to be incontinent. So that's probably a mistake. Parkinson's patients who are older men all have BPH, and that needs to be addressed as well. Mobility concerns are a really big deal for folks with Parkinson's, right? We can do all these fancy things to their bladder, but if it takes them 10 minutes to get to the bathroom, like, we're not fixing that with botulinum toxin. So I'm sure you guys are all savvy at this, but right, talking to them about commodes and bedside urinals and even external catheters to assist with symptoms is very, very important. Other Parkinson's treatments like deep brain stimulation probably helps their urinary function. Okay. Multiple sclerosis is a demyelinating disease. It can affect it frequently affects the spine, but can also affect the central nervous system. And because of that, the urinary function impact varies. So again, urinary involvement in 50 to 90%, huge portion of these patients have voiding symptoms, and the incidence of the voiding symptoms is really related to their disability status and mobility. So kind of higher burden of disease, they're more likely to have voiding problems. UDs can show overactivity. These folks can get true sphincter dyssynergia depending on what part of the spine is involved. Anticholinergics and catheters used to be the cornerstone of therapy. And just so we all know, Crede and Valsalva are really contraindicated in the setting of sphincter dyssynergia, okay, because we're just kind of adding to that pressure, which can ultimately cause kidney damage. Spinal cord injury, I feel like we actually talked about quite a bit. Depending on the level, right, they can end up with all different kinds of abnormalities. Urinary dysfunction, extremely common. What did I do? I forgot to update this. All right, well, depending on the level of the spine involved, right, you can end up with impaired compliance, you can end up with incontinence from overflow or incontinence from detrusor overactivity, and your treatment's really going to target what their problem is, which is very much based on what level their spinal cord injury is on. And this is just an example of what sphincter dyssynergia looks like on X-ray, right? Everything is dilated, the bladder neck's wide open, and then it all comes to a halt at the sphincter. This is a female and this is a male. Outcomes in these special populations, all really improved quality of life, very happy with increased improvement in frequency, incontinence, and kind of overall symptom scores. Lots of long-term data in multiple sclerosis about safety of botulinum toxin in multiple cycles. In children, botulinum toxin is used actually down to age 2, and that's based on FDA data using botulinum toxin in cerebral palsy. So although it's technically off-label to use for neurogenic bladder in children, it is used and seems to be pretty safe. And in fact, frequently gets patients off of medical therapy and has decreased need for urinary diversion in 90% of kids who failed CIC and antimuscarinics, which is pretty wonderful. In interstitial cystitis and bladder pain syndromes, we talked about this a little bit, right? So the analgesic properties and reduced peripheral sensitization, all this sensory action of maybe not the primary Botox function, but these secondary and tertiary actions of botulinum toxin, very important for interstitial cystitis. So not only are they getting improved frequency, urgency, but they're probably getting a lot of direct impact on calming down their sensory, their aberrant sensory activity. Okay. Adverse effects. Commonly, dysuria, urinary tract infection, hematuria, elevated post-void residual. When the urinary retention happens, It peaks at 2 weeks and usually will last something like 6 to 8 weeks thereafter. Discontinuation because of adverse effects is low, only 1.8%, all right, which is much, much, much better than taking antimuscarinic oral therapy. Urinary retention and need for intermittent cath, only about 5%. Tachyphylaxis, meaning sort of becoming resistant to the Botox over time, pretty uncommon. Transient muscle weakness, right, from this theoretical idea you could get botulism from Botox, has never been reported with Botulinum Toxin. Botox has been reported with Botulinum Toxin. However, we all recommend kind of caution in high-risk patients, children, patients with low pulmonary reserve, and myasthenia gravis, patients that have abnormal cholinergic function to begin with. All right, I'm going to go through this really quick because I bet Dr. Stevenson's going to cover this. Ready? Okay. Non-muscle invasive bladder cancer, the TAs, the T1s, the CISs, all really benefit from an adjuvant bladder therapy right after resection. BCG is a active mycobacterium, right? So it's a bacteria that we put into the bladder to use for immunotherapy. When we put it in the bladder, it induces this acute response, releasing a bunch of cytokines, again from our very effective urothelial cells. Neutrophils, dendritic cells, and macrophages are all involved in kind of activating this huge immunologic cascade. And then our T cells, which have memory, get involved, and once everything's activated, our dendritic cells bring bring antigens, could be mycobacterium, but hopefully is tumor antigens, into the lymph nodes, and it's kind of like getting a vaccine, right? Our T cells remember what these little antigens are, and then there can be a durable anti-tumor response, again, assuming some of the antigens that are brought in and develop T cells are actually tumor antigens. Why intravesical therapy, right? Similar to botulinum toxin, we avoid systemic toxicity that you would get with a systemic chemotherapy, and we're directly targeting the tissue that we want to target. BCG outcomes, BCG after surgery is superior to surgery only, and also BCG is superior to single agent intravesical chemotherapy. However, as you're all aware, we've been kind of suffering from this BCG production shortage, allegedly because bladder cancer is more common than it used to be. There was like one factory that was shut down and had some kind of major supply ramifications. So fortunately, the AUA and the SUO published some strategies to optimize care in non-muscle invasive bladder cancer. So key take-home points. All right, and again, save your questions for Dr. Stevenson. Low-risk disease should not be treated with BCG, okay? Intermediate risk, intravesical chemotherapy should be used as first-line agent, okay, for those kind of recurrent or multifocal low-grade TA patients. They can get mitomycin, they can get gemcitabine or epirubicin docetaxel. If BCG would have been administered as a second-line therapy, basically use one of these other agents, okay? We have other options for the intermediate risk disease patients. High-risk disease, so for high-grade T1 CIS patients, when they're getting induced and they're BCG naive, these are the patients we most want to use the full-strength BCG. This is where we want to reserve BCG for them because they get the most benefit from it, okay? If it's not available, you can reduce, or limited availability, you can reduce your BCG dose to half or 1/3, all right? If there's no BCG whatsoever, the preferred alternative is to use mitomycin. You can do induction and maintenance therapy with mitomycin. Patients on maintenance therapy, we should preserve our BCG by giving 1/3 or a half dose and limit the maintenance therapy to 1 year because that's getting the most bang for our buck, okay? If it's not available, just skip maintenance therapy altogether. If mitomycin C was used for induction, then you can also use that for the maintenance therapy. Patients with high-risk features on top of a high-risk disease should probably just be offered a radical cystectomy if they're a good surgical candidate. So this is the high-grade T1s with CIS or lymphovascular invasion, prostatic urethra involvement. And as with anything, the oncologic risk of giving some of these patients a second or third line drug is not well known. So particularly in these patients who are very high risk, you really need to disclose to them. A lot of them are probably familiar with the BCG shortage, to be honest, but to really talk to them, we don't actually know what the increased risk is of doing these alternate regimens. But using kind of data and how we know these things work, following this kind of algorithm will, again, kind of do our highest yield, bang for our buck, giving the patients who need it most BCG. Again, these kind of high-grade T1 CIS getting induction have never had BCG before. Those should be the priority. Quick note on split dosing. Really have to work with your insurance companies, right? I think there are a lot of concerns from a hospital billing perspective and by insurance companies on kind of how to use one vial and use it on 2 to 3 other patients. So CMS, I think the AUA is still awaiting CMS guidance, which is hilarious because the crisis will probably be over before they give us any guidance on this. But you can always talk to your insurance companies directly to kind of get an idea of how the office should be handling this.